We're going to take a moment here in this lecture to talk about cancer, but not specifically different types of cancer, and going through every single type of cancer, but what is cancer and what should we as paramedics know when caring for a cancer patient. First and foremost, what is cancer? So cancer broadly is uncontrolled growth of abnormal cells and the spread of those abnormal cells with some DNA mutations. It's a group of diseases. It's this umbrella term, so lots and lots of diagnoses under the term cancer, right? These abnormal cells can clump together, they can form tumors, they can spread, and they can invade and destroy our normal tissues and normal cellular functions. And the median age for cancer diagnosis is 66 years old, and there's several dozens of factors that can lead to cancer, but we've got big ones: long exposure to your environment, whatever kind of a toxic, carcinogenic environment. Over time, you've got this accumulation of cellular damage in your body, and as we age, our normal immune system is blunted a little bit. There are varying categories of cancer, types of cancer. Some are carcinomas, others are sarcomas, so kind of depending on where they're found, where they grow, like lung cancer or cancer in your bone. So carcinomas, sarcomas, you've got leukemias, lymphomas, and then you've got cancers of the central nervous system, cancers within the brain and the spinal cord itself. So these types of cancers, are they in your blood? They're blood forming. Do they involve your lymphomas, your lymphocytes, your T cells, your B cells? And once diagnosed, you'll hear different stages of cancer. So stage 0, cancer cells are there, but they have not spread to even nearby tissue, all the way through stage 4, which is metastatic cancer. So now the cancerous cells have spread to even distant parts of the body. So this is your end stage, your advanced stage of cancer, where those cancerous cells have spread globally. So why are we going to be called out to a cancer patient? It's not because of the cancer itself. It would be because of the various symptoms alongside it and side effects or effects of the cancer, right? So pain is a frequent one, frequent call out for cancer patients. So treating their pain is important. Being called out for shortness of breath. These patients are at high risk for infection. We get called out frequently for just altered mental status in our cancer patients. Some cancers and treatments for those cancers can cause bleeding, so you might be called out for hemorrhages. And then medical devices. The medical devices at home, there may be complications with that, maybe complications with their PICC lines, if they've got a PICC line in, or feeding tubes. So going out and troubleshooting any home issues they might have with their devices. And then we do have to talk about cardiac arrest and going out and how to care for a terminally ill patient, a terminal cancer patient who's gone into cardiac arrest. So with that, let's talk about palliative care and hospice care. So palliative care is this approach to care with patients with serious illnesses. It is multidisciplinary in practice, so bringing in multiple experts from multiple disciplines to provide care for this serious illness. The goal here with palliative care is to improve quality of life for the patient and for their family. Palliative care can be started at any stage of a serious illness, even from minute 1 of the diagnosis. So Even if the prognosis is you may have another 5 or 10 years. If it's a serious illness, you can reach out for palliative care, in which, again, treatment goals are provided alongside normal medical treatment, let's say like chemotherapy. But here, palliative care focus is going to be on symptom management, controlling nausea, controlling pain, and lots of support on the psychosocial end of things, lots of communication. So again, palliative care is meant to increase overall quality of life for the patient, for the patient's family, and this multidisciplinary approach is going to include a team. There are going to be social workers, there are going to be specialists, there are going to be nurses, there are going to be everyone in the healthcare arena can be involved in palliative care. Now, palliative care is going to differ from hospice care in that hospice care is a more specific type of palliative care, and it's for patients who have generally less than 6 months of life left if the disease is to run its normal course and the prognosis is accurate. So when hospice care begins, unlike palliative care, which can begin as soon as the diagnosis is in, hospice care will begin when our medical treatments, our curative treatments are no longer an option, or the patient has chosen to end those treatments. So the focus here is on comfort and quality of life. Hospice care is not focused on curing the disease. The patient isn't looking for that, isn't looking for these prolonged treatments. They're looking for comfort and quality of life in those last 6 months. So usually provided in the patient's home, can be in a facility. There are special hospice specific facilities, can be provided in skilled nursing facilities, nursing homes, wherever the patient is most comfortable or able to live out the rest of their life. So hospice care and palliative care share some qualities, but they are a little bit different. So these are both for patients with significant illnesses, severe diagnoses. Both focus on comfort care, symptom relief, and quality of life. But palliative care can be started first at the time of diagnosis. It's more holistic in general, can have that curative intent, so it's provided alongside curative treatments like chemotherapies, whereas hospice, later stage, 6 months or less to live. We've moved on from curative treatments, and now we are focusing solely on comfort and quality of life. So how do we, as paramedics, fit into this palliative care and hospice care system? Well, communication is key. Talking to the patient, talking to their family, asking very direct questions about goals and what care they prefer, what care works, what care they rather not receive, whether or not they are enrolled in hospice care. If you've got a palliative care patient, are they enrolled in hospice? If you have a patient who has a serious illness, it's not inappropriate to ask if they are enrolled in palliative care or hospice care. And then with that, managing their symptoms. So we're gonna treat as appropriate. We're gonna treat pain, gonna treat shortness of breath, treat anxiety. We are gonna continue within that palliative and hospice care systems. We're gonna continue those comfort measures and continue those quality of life measures within our protocols. Now, when responding to a hospice patient, there are some actions we need to take and be mindful of as we take care of that hospice patient. First and foremost, we're going to ask why we were called. So they're on hospice. Their prognosis is less than 6 months. So why are we out here today? Why was 911 called? Not in a judgmental way in any way, shape, or form, but what's going on today that's different that we can help with. And we're going to make sure that the hospice team has been contacted. Typically, the family will contact the hospice team first, and it's probably someone on the hospice team who has told them to call 911 for whatever's going on that day. But if they haven't contacted the hospice team, make sure to make contact with the hospice team. Review any pulse forms, any DNRs, any advance directives, powers of attorney, any paperwork, any of that legal healthcare paperwork that can guide our management of what's happening right now and can continue their hospice care and continue that quality of life and those comfort measures. So we're going to do that. We're going to contact hospice, the hospice team. We can coordinate with the hospice team for any treatments we can provide right there on site, or coordinate with the hospice team for transport. So at the end of things, we are going to prioritize the patient's wishes, assuming the patient is alert and oriented. And then some ethical concerns here with your hospice patient, just to think about. We do want to respect patient autonomy, and so our patient's right to choose their care. Hopefully this is documented either in a pulse form or some other manner, but we do want to respect that patient autonomy. And then so, we're kind of thinking do no harm. We're thinking provide comfort. And in some cases, transporting a patient to the hospital might actually cause more discomfort, cause more harm than just providing care there on scene. Let's say they're in their home. So kind of weighing the comfort considerations versus just assuming that we're going to take them to the hospital. Documentation with these patients also becomes even more so important. So we're going to very accurately document patient status, anything that the patient is either refusing or asking for, that their right to choose, right? They're alert, they're oriented, they can coordinate their care however they'd like. Any medications that we give, clearly document those, obviously, but any medical direction orders, if you've called your medical director, spoken to a physician, gotten orders, so accurately documenting those conversations, and then any conversations with the family, with the patient themselves, with hospice care about their care goals and how we can help those goals and function within that hospice team. And then any healthcare paperwork like pulse form that the patient, the family has, will be very important to document. Now, if we do not coordinate with that hospice team, there can be kind of downhill effects here. So if we don't coordinate with the hospice team, kind of take in the information that they are on hospice care, but kind of throw that information to the side. We take the patient to the ED. It can cause some major headaches. So first off, the hospice agency is themselves responsible for arranging for and paying for all care related to that terminal illness, and if we don't coordinate, that can lead to either bills being uncovered, unpaid, or even a full review of the patient's hospice status in which they can be taken off of hospice. Now that sounds scary. So here's the question. If we take a hospice patient to the ED, does that automatically cancel their hospice care? And short answer, no. So we can still take them to the hospital, right? It doesn't automatically cancel hospice care, because the reason why we're called out that day, remember, we're asking that extra kind of silly question, like, why were we? He's got this terminal illness. Why are we called out here today? So the reason why you're called might be completely unrelated to that illness. Let's say they fell that day and broke their arm, right? So that's unrelated to their lung cancer. So that will be completely covered. and no issues there. And then reasons related to the terminal illness, so uncontrolled issues, severe shortness of breath, completely uncontrolled pain, or other issues related to this terminal illness. Say, go back to that lung cancer. If they are severely short of breath, severely hypoxic, please, hospice team is 100% going to tell family to call 911. So we just need to make sure that we are coordinating with the hospice team and that the hospice team has been notified. As always, if you have any questions, please let us know.